Thank you. Which one is the good one? This one? Okay. Yeah. With the errors. So, first, I would like to thank really the organizing committee for having invited me here. It's really a pleasure. And I will also represent the French Society of Arthroscopy here. So I'm really proud to speak here. And I will show you mainly our results. So this talk is quite, I think, difficult to really say everything or try to focus on the real problem of the athletes and not put it on the black box that is the subacromial impingement syndrome. So this is my disclosures. So shoulder pain for athletes is something really common. It will encounter for 11 to 15% of the whole population. And it's always said that the medical treatment must be start right away and will improve the athletes, will give him a relief of every symptoms. But there's no evidence-based medicine or results on this. And finally, when we look closely on the different papers, we see that we have to manage a wide range of diagnoses regarding the shoulder or the whole arm, the neck, and in center, we just have shoulder complaints. In these last 3 decades, there's an increased common diagnostic. This is a painful shoulder, athlete's painful shoulder. But this means nothing. Because clearly, an impingement should be a specific diagnosis and not symptoms. So by this way, we have different clinical presentation for this shoulder pain. So clearly, the diagnosis of subacromial impingement is a black box where we put everything when we don't have any ideas of or idea of what's going on. And this leads to a lot of misdiagnosis and, of course, complication and unsatisfactory results when there's no other solution. Okay, we will run for an acromioplasty and subacromial decompressions. Complication is quite high, over 20%, and if you look closely on the different data, most of the time there's something like half of unsatisfactory results. So with time, there's many subgroups that have been defined. There's the impingement syndrome. We will focus on this, but we can also have rotator cuff tendonitis, the frozen shoulder, or minimal symptomatic frozen shoulder we have to deal with. AC joint disease, we treat this in the former session. There's also some nerve problem or nerve issue around the shoulder. And there's no specific criteria, so by this way, for all those subgroups, there's no uniform definitions. And that means that it's a challenge to diagnose all these shoulder pains and all these syndromes. So first, the clinical examination remains crucial. And there's many tests, maneuver, more or less reproducible, that will reproduce the pain. And all these tests over the shoulder, when they deal of specific impingement around the shoulder, have in common that they will narrow the space between the cuff, the tendon, and the course of the tendon. So the patient mostly come for functional loss and disability and pain. It also said that he feels some weakness around the shoulder. And when we can get rid of the pain, the athlete said that there's no more weakness and it should remain no stiffness at the end. So the physical examination, most of the time, will help to get the differential diagnosis. What do we have to deal with? Acromion or sacromiale impingement, that is excluded from this talk due to because we have to deal with other impingements. The acromioclavicular joint, we had specific talks just before. Internal impingement, I will try to make many comments on this, and the coracoid process impingement, that's the second impingement we will deal with. We may have also other intrinsic factors for those patients, muscle weakness, labrobicipital tears, maybe. This is will not be treated in this talk, and also extrinsic factors just like neuro and instability that will be treated later on. For all those patients, they must have also radiographic evaluation that will help in the diagnosis. So I will focus right now on internal impingement, and we'll just show you the studies we did last year for the French Society of Arthroscopy. The first study was to define, is the internal impingement a physiologic contact? We did a prospective study based on patient examination under arthroscopy for different positions, just like this. And the conclusion were that the contact is physiologic. That was already published. And we found no favorizing sports, but also found that with repetitive positioning in abduction and external rotation, we can see more frequently this contact. Then we tried to look at the pathogenesis with a cadaveric model, and we found that if you have posterior and inferior stiffness of the capsule, you increase the contact and the pressure of the inferior part of the cuff with the posterior labrum. Then we look at, in a retrospective cohort of 135 patients, all those patients had an anterior capsular shift, not all. Some had an anterior capsular shift, some others had posterior capsulotomy based on the study we did just before, and some others had a posterior glenoidoplasty. And if needed, all those patients had a cuff repair, but no debridement of the cuff. And the results were not good, not so bad, because 98% of the patients went back to sports activity, and 52 at the same level. And the positive factors for success of the surgery and the success to go back to sports activities were male with a rotator cuff lesion that was fixed instead of being debrided. And also when there was no degenerative changes on the humeral side and on the glenoid side. So those results were comparable to the literature. And we found also that an anterior capsular shift in this situation is no more an option because it leads to post-operative pain. And if you see cuff lesions, they have to be fixed and not only debrided. Regarding the second impingement, I would like to talk about the subacromial impingement. There's many papers in the last 2 to 3 decades and less right now. It happens in elevation and internal rotations, and it's a contact between the deep surface of the subscapularis and the anterior superior labrum. And it will lead to lesions of the subscap and the biceps pullae, more or less with the labrum. There are maybe 3 causes: idiopathic, with anatomical variation of the coracoid process, iatrogenic, after the surgery, and traumatic in case of some proximal humerus fracture. Some authors found that that might be a problem of anterior instability associated with. The diagnosis is based on the examination and also on radiology with the coracoid index. That's what is in red there. The radiology also helps us to find subscap tears. The treatment option is first conservative, and then, as was emphasis with the Millet group and published by Mark in Casistia in 2012, the coracoidoplasty. This is his images. This will really give a pain relief and a functional improvement for those patients. But if we look all the papers, they're just small evidence-based results. So this is really something that has to be done, but not with a high proof level. So in conclusion, we can say that we have a wide spectrum of so-called subacromial disorder, and we have to focus on the posterior and anterior impingement too. All have similar symptoms: pain, weakness, and cuff deficiency. There's a lot of differential diagnoses that we have to focus on, and always remember that an impingement is a clinical syndrome and not just symptoms. Make sure that all the patients have a passive range of motion symmetric. We have to focus also on the ACGen, the cervical spine. There's many tests, and we have the help of the radiology to really improve our diagnosis. Thank you very much.
Thank you.